Good afternoon, everyone, and thank you for joining us. You're joining the American Professional Society for ADHD and Related Disorders Association's education webinar. And today, the title is Stimulants, Friend or Focus, Friend or Foe. The focus is on stimulant medication and its misuse by a good friend and noted colleague, Dr. Timothy Wilens. My name is Dr. David Goodman, and I'll be your moderator today. Just to let you know, ABSARD is the only American professional society that addresses ADHD across the lifespan. Its members are some of the leading national and international experts in research and clinical practice. We hold an annual conference every January, and in 2025, we'll be in San Diego. So we hope with the credibility and expertise of this webinar, you'll see why ABSARD is noted for its state-of-the-art information. Given the importance and prevalence of ADHD in the United States in adults, ABSARD is currently developing the first U.S. clinical guidelines for the diagnosis and treatment of ADHD in adults. Our process was published in a series of free CME articles in Psychiatric Annals in fall of 2023, and you can access those articles through the QR code you see on the screen. So given your interest in ADHD, we hope you'll have the opportunity to read the Psychiatric Annals articles and extend your understanding of the exciting new developments and the process of developing clinical practice guidelines. Now, let me get to the introduction of our esteemed speaker today, Dr. Timothy Wilens. Dr. Wilens is the Chief of Child and Adolescent Psychiatry. He's the co-director of the Center for Addiction Medicine at Massachusetts General Hospital. He is a full professor of psychiatry at the Harvard Medical School. He specializes in the diagnosis and treatment of ADHD, substance use disorders, and bipolar disorder. Widely published, he has more than 350 original articles and reviews, 90 book chapters, 6 books to his credit. He's also a consultant for the National Football League, the Major and Minor Baseball League, Bay Cove Human Services, and Gavin Foundation. And he's consistently named one of the best doctors in Boston and in America in psychiatry. And I know exactly what you're thinking. The man sleeps about 2 hours a day since he was 18 years old. So let me introduce Tim, and I'm so glad, Tim, that you've come here, and we're going to have a great discussion and great banter.
Well, absolutely, David. And thank you so much for inviting me and for leading these conferences. It's a real honor to be here, and ABSARD is a great organization. And there's a lot of familiar faces, so hopefully we'll have a really nice conversation at the end. And I'm going to jump right in, grab my slides here and get started. Before you go, Dave, everything okay? People can see okay there? Great. So we're going to talk a little bit about ADHD and stimulants, friend or foe, and it's going to be more on the concerns about stimulant misuse. So I want to just prepare you for that. I'm going to start. You already heard some of my disclosures. With this, there's only one compound where it's actually beyond conflict, but we're beyond the time. But just to let people know, most of the funding for my laboratory, and I appreciate this, comes from the National Center on Drug Abuse and the U.S. Food and Drug Administration. So I work with University of Michigan on FDA contracts that are specifically in this area. They're very interested in stimulant misuse, what's real, what's not, et cetera. So today we're going to take a look and better understand both the short and long-term effects of stimulant treatment. In other words, put it in context, learn a little bit about the relationship between the two, but really spend all of our time on this last one, really understanding stimulant misuse. And then there's going to be plenty of time for Q&A at the end. So write down your questions or follow the recommendations in terms of that. So just to remind everybody about ADHD, sort of an overview. You've seen this before. The prevalence varies, but it's in the 6 to 9% range across the world. It's about 4 to 5% in adults. It's got a chronic course that we know about, high rates of psychiatric comorbidity, multiple impairments, right? That's why we treat ADHD. So it's not an option not to treat ADHD. It's a clinically derived disorder, and it responds very well to treatment. And one of the most responsive treatments that we have are the stimulant medications. They're highly effective for the treatment of ADHD. Now I'm going to jump quickly so I can introduce one of the things we always worry about, which is an overlap between ADHD and here substance use disorders. SUD is substance use disorders. And this is the presumed overlap if you don't treat ADHD. In other words, if you let people grow up with ADHD, never treating them, about half of ADHDers will develop a substance use disorder. If you start with those people with a substance use disorder, about a quarter of adults, it's up to here for adolescents, 50% of adolescents, but about a quarter of adults with a substance use disorder have ADHD. Now, this is not a talk on ADHD and substance use disorders. I love giving that. Always happy to come back. But the reason I'm bringing this up is because it's really important, and it comes back up when we talk about stimulant misuse, that this group here in the middle are one of the groups that we really worry about with stimulant misuse. Data shows it from both directions. So I'm just planting that seed there and putting in context when we're talking about ADHD and stimulant misuse or substance use down the line. Remember that if you just take stimulants out of the equation, there's still this big overlap that exists. So now one of the biggest issues we worry about and think about is, stimulants. Are they a friend or are they a foe? And this came from an article, an editorial to a big review article on it. And the important thing to realize is that there is stimulant misuse. I mean, we're going to spend a lot of the time talking about it, but it's important to realize that in addition to stimulant misuse, we have to be able to put it in context to the absolute importance of the treatment of ADHD with stimulants. Stimulants work well for ADHD. And the stimulants, to remind people, I just put this up here. This is our more recent table of how many stimulants. We have 15 different preparations of methylphenidate, MPH, for ADHD. And we have 10 different products available for amphetamine in ADHD. I will say that one of the concerns of DEA, for people who may not have been on a webinar about 2 or 3 weeks ago, the DEA made a concern that all these different preparations that are now available with more marketing, they're concerned, is there going to be more stimulant misuse? Is it like the opioid epidemic where all the marketing of the different opioid preparations seems to have increased the use, which downstream increased opioid misuse, use of heroin, fentanyl, et cetera? Is that also the same with ADHD medications? It's a question. I want to start just reminding people of things that you already know, but it's also good to know, and it keeps it in context when we jump to stimulant misuse, which we will in a few seconds, which is there's definite concerns that medicines may, cause or result in problems with things such as like brain, neurotoxicity, et cetera. Well, with stimulants, it's absolutely just the opposite. And that is, if you look at typically developing ADHD individuals versus treated ADHD individuals, you'll see that these two groups look the same, and it's the untreated group that have the less healthy brains. So from a structural study, and by the way, this is the big ABCD study, this is a cross-sectional study, but this is a huge finding. It's big sample size, 273 and 1,000 untreated versus 5,500 typically developing. So my point is that the stimulants actually from a brain health perspective seem to be very positive. And this is just one of many studies. This was an aggregate looking at functional outcomes over time of the stimulants, showing if you look long-term with stimulant medications, you see improvements in accidents and injuries, reductions in mood disorders, reductions in motor vehicle accidents. That's actually improvement in academic outcome, decrease in adverse academic outcomes. So it's an improvement, reduce motor vehicle accidents, reduce substance use, suicidality, and traumatic brain injury. So that long-term, we're seeing significant effects associated with things that we know are more problematic in ADHD if you don't treat. So again, the context are that stimulants are highly effective, both short and long-term, in the treatments of ADHD. And what about substance use? Because we're going to be talking about substance use. And I want to remind people as we look long-term, if you look at ADHD and later substance use, ADHD doubles to triples the likelihood that you're going to have a substance use disorder, especially in the untreated group. If you treat, it appears to reduce that risk. Doesn't immunize you. You still are at risk for substance use, but it reduces that risk. And the biggest study to date is Patrick and Quinn's work that was done 3 million ADHDers. They showed within group during times that you're treated versus untreated, 35% reduction. And if you look between the groups that were treated versus the groups that were never treated, a 50% reduction. And it turns out it really matters when you begin treatment. So this is work that Sean McCabe from the University of Michigan, I collaborated on this. We did, which looks at marijuana use in 18-year-olds. This is the population risk. And if you're on stimulants and you started it prior to age 9, there's no difference. But if you wait to start the stimulant in middle school or high school, you'll see these individuals, these groups actually were higher. So, and the reason I'm also showing that is first, just to remind us that treatment doesn't cause substance use, but that we do start to see signals of higher marijuana use. And the question is it just the ADHD effect? Look, you didn't treat ADHD, and later on you developed cannabis use. So not use disorder, but cannabis use. So is it an issue of you just didn't treat and ADHD untreated led to that? Or is starting stimulants later actually leading to increased rates or risk for, in this case, marijuana use? And again, there's a question on that. That's being examined right as we speak. We don't know it. Is there a developmental time that you start stimulants that you have impacts? We do know this, and this is not the only study to show it. Starting before the age of 9 seems to give the best outcomes over time. And if you think heuristically about this, it would be not dissimilar from starting antihypertensives for blood pressure. If you start them early, keep people on them, you'll see better outcomes for stroke, cardiovascular issues. If you wait, as arguably here it was waited, they waited, and you start them later, you're not going to see the same effect. And if you stop them, you lose the protective effect that antihypertensives create in terms of later cardiovascular events and stroke. So again, let's come back to this question about this friend or foe. We've talked about the friend. So I'm not going to speak much more about that component of it, but we now know that there's also a foe consideration here. Let's put it first against the backdrop of what has happened with stimulant pharmacotherapy recently. So this just shows you over the years, and this gives you sort of the stimulant, non-stimulant. This is all pharmacologic agents we use for ADHD. These are the non-stimulants in the red. And here in the blue are the stimulants. And you can see they're all sort of taking the same increase after the pandemic. You start to see this increase here that has continued. And their DEA is very concerned about that. And they've pointed that out, that there's been this big increase. This exceeds where it was pre-pandemic. It appears to be more in women with ADHD, adult women with ADHD. And the prescribers appear to be nurse practitioners. I'm not saying it's right or wrong, but nevertheless, that seems to be where it's occurring. And that these increases that you see here, and it keeps going, are catching people's attention, particularly as you start to see, this is overall overdose deaths. The good news, by the way, that's dropped. But also you start to see overdose deaths with cocaine and psychostimulant involvement here. This is any kind of involvement, stimulants with synthetics, opioids like fentanyl, and stimulants without any opioids. So the stimulants themselves have increased, but stimulants with any other combination are clearly there. And the two organizations I work with that are not that are more clinical services, I work and I cover detox units, and we see a lot of stimulant. We see a ton of methamphetamine and cocaine. And one of the questions people have, and you may be called by the media on this, is we have this increase in the, let me see if I can get us back. We have this increase that's occurred here with stimulants in particular. And we have this increase that's occurring with the overdoses. And the question is that, are they lined up? Is that directly related to that, prescription stimulants and overdoses? So NMU, I'm going to be using misuse of stimulants, but you'll see a whole lot of different ways they call it. They call it the non-medical use. Non-medical use would mean it was diverted to you and you used. Diverted means somebody gave it to you or sold it to you and you used. It could mean that you used your own stimulant prescription at a higher dose or you sold it. So we're using these sort of interchangeably. I just want to let people know. So non-medical use is misused. You'll hear me say that. And you can see it even here, NMU, misuse. But kind of what I want to point out is if you look at, misuse of stimulants, this looks at cocaine use, this looks at misuse of prescription stimulants and methamphetamine use. There's quite a bit. In fact, prescription stimulant misuse is the most misused prescription medication by individuals now. It's more than benzodiazepines, and it's more than opioid. This is another statistic that we found in our analysis that kind of floors you out. It's more people misuse prescription stimulants than are prescribed them. So it's a pretty big group. Now, the good news is not all of these people are stable. Most of them are not stable methylphenidate users or amphetamine users. They use them once or twice or 3 times, and that's it. But there still is a group that we're more concerned about and that we kind of are keeping our eye on in terms of potential issues. For those people who are interested in the kind of studying this and understanding it, there was a really nice review a few years ago by Steve Ferrone and a number of APSARD members here, Steve, Tony, Kevin, Jeff, Oren, and others, Brendan. These are well-known people that have done this. And I thought it was one of the best kind of reviews of this update. And what they said is that the majority of non-medical use is associated with no or minor medical effects. However, adverse medical outcomes, including death, occurred in some, especially by non-oral routes. And that is associated with significant impairment. The other thing they say that I think is important, and if you're working in this, rather than just be fearful and say, yeah, some people are using, there's nothing to know about it, realize that non-medical use of stimulants is a significant public health problem, especially in college students. It is an issue, and we need to deal with it. And I'm just letting you know, from the webinar we had, we either police ourselves and start to talk about it and kind of try to do what we can to clamp down on it, or we're going to have our associates at the DEA who are going to be entering into that and doing that. I mean, they're signaling the alarm. We know that it's out there. So, and it is a significant issue. And the reason I'm saying that is because when I first started work on this, I thought it's not a big deal. Some people misuse, but it's not. But it turns out there are some that misuse that may be a problem. And I think there are things we can do as a community of treaters, prescribers, people who work with people who are being prescribed the medications that may help. So let's take a little look at where is it occurring? Well, first of all, it's occurring in 20 to 23-year-olds. This is college age kids. And in fact, when you look, it's just remarkably Gaussian, isn't it? Number 2, it's largely in college students or college-prone students. You don't see as much stimulant misuse, prescription stimulant misuse, in individuals, let's say, who are in the trades, individuals who are not in college. There you tend to see more benzodiazepine or opioid misuse, but stimulant misuse tends to sort of hang around college or college settings. So bing, you're working with college students, you really need to think about prescription stimulant misuse. You really need to add now a conversation that we'll talk about at the end for these college students. What are some things we know? First of all, there's a lot of studies. People say, oh, we need to study more. I'm not sure we need any more studies in terms of the prevalence. We need to keep an eye on it, but it is still quite prevalent. And we know that if you look at it, the prevalence of non-medical use consistently in college students runs between 10 to 20%. If you look at where the medicine's coming from, the majority is diverted from friends or from individuals' own stashes. And I'm going to show that in a second. The majority, and this is another important case, the majority are not people coming in and scamming their local practitioners, going to college mental health, or if you're working around a college setting or in a area, they're not BSing their prescribers to try to get the medication. And now again, you're going to get some people like that. A lot of people say, well, how do you know that group? Well, I say use common sense. I've had people where I've suspected that they come in and they've memorized the DSM. So before I can even start questioning, they go, hi, I'm Joe, and I have inattention, distractibility, shifting activities. Frequently I have problems with poor control, and they go on, and then they say, I'd like Adderall 30 milligrams twice a day. And then, I'm like, okay, all right, it's a suspicious thing. So what I do, I use rating scales. I say, probably good opportunity to send these home. Let me talk to your parents and move to the next level. It's a very serious diagnosis, and you slow down the diagnostic process. My experience working with a lot of different college students at different ages and doing ADHD work for years, the people who I think were scamming kind of tend to go away. So this is a more recent paper that helps 2023. I think we see this slightly upward trend. But again, this is making the point that the non-medical use of prescription stimulants remains more prevalent than prescription opioids, tranquilizers, and sedatives. So it's at the top, and it's not even close anymore. And then we're sort of following these groups to try to better understand what are the implications of this and who are the people. What I'm going to shift to now is to talk a little bit about diversion, so we get a better sense of who's giving away, selling their medications. What is the pattern around that? So we might be able to do something about it. And so diversion is somebody gives it or sells it to somebody else. How is the supply getting into other people's hands? So I thought this is interesting. This is from a group, and this looks at the diversion sources of prescription stimulants. Notice the date. So this is over a decade ago. And for those of you who would have been on a call if I was talking about it then, I would have said, this is where it's coming from. It's given for free by a friend or a relative. That really was most of it, friend or relative. And that seemed to be where most of it was coming from, not much left over, but mostly that. What I want to point out is, look now what's happened. So this is kind of the same system that we're using to diagnose and do everything, but this is 10 years later now, more contemporary. And here you can see that my leftover prescription is really adding to the regimen. In fact, it's the majority. And in other survey studies, it's even higher. So there's been a shift from just giving it free or getting it from a friend or something to people getting stashes of stimulants and then selling them or giving them to somebody else or misusing their own. And the reason I make a big deal about that is because I'm going to tell you, and I'm going to repeat it again, one of the things we can do is right-size prescriptions. That is, not to give too many pills. One thing you learn for those people who do addiction work, I was just supervising a junior faculty member earlier today, and there was concern about the stimulant for this person who has rip-roaring ADHD. And what we've done is we only give because we're concerned that they use it properly, et cetera, not to tempt fate, not to give a big supply. And we're really stabilizing this person early in treatment, very early in treatment. Every 3 days, giving a prescription, we're going to move it to weekly. And that's a very common thing you do in addiction care for people who have a co-occurring problem and you're thinking of using a controlled substance. You give very small prescriptions because they tend not to misuse, because they don't have that many to misuse. They don't have this massive supply. Contrast that with people where now, I had a question from another junior faculty earlier. Commonwealth of Massachusetts has allowed now 90-day supplies, and the feds allow a 90-day supply. I do not recommend 90-day supplies of stimulants in general practice, especially for this age group. I appreciate they're going to colleges and things like that, but I think you have to limit the prescriptions because of the concerns that we have about misuse. And I'm going to keep making that point over and over. So I call it right-sizing the prescriptions. Give people what they need, but we can't give a lot too many. And I know that there's concerns with shortages. What does that mean? Here's another study, sources of non-medical prescription drug use. This is a different sample and looks at high school seniors. And again, reservoir of medication supply, excess numbers of pills and capsules resulted in the most diversion. This is an entirely different data set, different sample, but one that, again, makes the point that having too many pills or capsules in somebody's hands, especially unsupervised. It's different if you have a parent locking it up, supervising it, etc. But you have to be careful because that's where you're going to start to see loss or bleeding of what's available. So I also want to take a little bit of look at what are the characteristics of those. What do we know about people who misuse prescription stimulants? So this was a study we did, an NIH study. There are two ways to do these studies. One is a survey study where you get hundreds, if not thousands of people, and you ask them, a few questions, or you take a smaller sample and you torture them with 1 billion questions and do a whole lot of things. And that's what we did. This was an NIH study. We studied 100 stimulant misusers and 200 controls. And here you can see what are their reasons to help concentrate or focus, to reduce distraction, but then you get some of the side effects to help stay awake. That's a side effect of the stimulant. And then consistently, you see this number here, about 1 in 5 to have a good time with my friends, to feel good or get high, and then a much smaller percentage probably for depression or depressive symptoms. So you do have some for euphoria and a lot for the effects of the stimulants themselves. And when we look at motivations in another study, we found cognitive enhancement with stimulants when we ask questions seemed to be the big thing. Young adults were more than adolescents, and college more than non-college. This is also one of the signals we had that people who misuse prescribed stimulants, so if you know somebody even took one off, they got somebody else's and they're coming in, they said it helped them, and so now they think they may have ADHD, or they admit to doing this, it's linked with other psychiatric disorders like depression and anxiety, suicidal ideation, and substance use disorders. In fact, I'll show you data. Half of those people who misuse stimulants, prescription stimulants, have a substance use disorder. And here we say it, and over, prevention is everything. Being on this webinar, thank you for doing that, because you're learning and now you're thinking about it and worrying a little bit about it. Now, this is an interesting, one of a research staff of mine, now just graduating Yale Medical School, very proud of her, did a kind of analysis of the literature looking at what do we really know about performance enhancement with stimulants? What happens if people who don't have ADHD take stimulants? What occurs? And these are the different studies. Here's the sample size and the design. And these are kind of the findings. What was interesting is you see a lot of minimal improvement, some improvement in CPT, but no, in the continuous performance test, but none otherwise, no effect. Dose impediment improvement, but still mild, no effect. And the other thing, so you don't see a very robust effect of stimulants in people who don't have ADHD. You see it in people with ADHD, but people who don't have ADHD, it's not clear they really do much anyway. And expectation, that seems to drive a lot of it. So if you think the stimulants are going to improve your attention and focus, that's kind of what drives that you have improved focus and attention. What we also know is they keep you awake. They have side effects. And so people bank on, like I showed you before, the side effects, but also largely the expectation. They're not that great as a cognitive enhancer. That's kind of what this shows. So a lot of people say, okay, if you just look at those with who are misusing on the right, and you compare them to non-misusers, what's your rates of ADHD? And this is broad ADHD. About a quarter of those people who misuse prescription stimulants in whom they're not prescribed have ADHD. So that's an increased rate over the general population. But it also means that 75% don't have ADHD. So they don't all just have ADHD. Well, what other things? This is using the behavioral rating inventory of executive functioning, the brief. It's a clinical scales of executive functioning, time management, hierarchical thinking, or a Wilens, as I might call it, secretary of the brain. And what you see is that across the board, those who misuse stimulants are about half standard deviation more, and different subscales of executive functioning compared to those who don't misuse stimulant medications. So they also have higher rates of executive dysfunction. So just in general, out there, people misusing stimulants, more ADHD, more executive functioning. And this is what I was commenting on before. This is looking at those people who were stimulant misusers versus general college students, same sample I was showing you before. And this looks at the development of substance use disorders in those who are stimulant misusers. 50% by the age of 20 already have a substance use disorder compared to regular college students. And this is about the rates, believe it or not, of substance use disorders in the general population. If you look by 18, about 10, 12% have a substance use disorder. And by the time you get there, it starts to approach 20%. So that's what it is. And it's twice as high. So what's the take-home message? Anybody who has been misusing stimulant medications, you would think that you have to rule out a substance use disorder because 1 in 2 of them have a substance use disorder. And this isn't the only study. I showed you another study, Monitoring the Future. All these big epidemiologic data sets consistently show that same rate of substance use disorders. So one of the questions we had is, are stimulant misusers who have substance use disorders different than those who don't have substance use disorder? And the answer is probably yes. So if you look at that, I've already gone through this, misusers with versus without substance use have bought or traded stimulants more. They do it in their car. They used at parties, used intranasally. I'm going to show that. And misuse at parties, use with cocaine, use with alcohol. So there is a difference between people who misuse stimulants who also have a substance use disorder. I can tell you right now, that's a pretty serious group. They really, when you scan, you pick up their substance use, that's a significant issue because there's a lot more stuff going on in that group. Now I want to step back, a little bit of neuroanatomy here. Everybody remembers the caudate, the putamen, and the globus pallidus here. This is our kind of thalamus, and this is where we're looking at dopamine binding, and I'm going to be showing you some data as to help us better understand some of the characteristics of misuse from a clinical perspective. What are some things we can do? And this is going to look at the use of different stimulants, immediate versus extended release, making the argument that extended release have lower abuse liability. And when I show you studies, it's binding in these areas of the brain. This is an older study. Look at this, from 1995. But this is Nora Volkow's work, and it's still very important. And she showed that if you give, let's say, IV methylphenidate, which that's not how we're administering methylphenidate, it gets into those areas of the brain I just showed you very rapidly, and it dissociates rapidly. And it's associated with more euphoria compared to similar dosing, but given orally, where it gets into the brain slower and comes off of the dopamine transporter slower, and that's associated with less euphoria. So we know that IV, anything, intravenous, intranasal, is going to give you more euphoria than oral. Okay, that most people know that, but it also is important to see the reason we think that is it's this slope right here. This is a very steep slope. This is not. So if you're climbing a hill, if you're a climber, this is going to be a lot harder than this. This is just going to be walking up the hill, and this is going to be you're using lines and other ways to get up the hill. I also want to point out that showed the euphoria higher in the group that did intravenous and made the comment about intranasal. When you look at the routes of administration or misuse, so how do people take stimulants, college students largely, but that group, swallow it 55%. That's what I would have thought it would have been way up here. But in this study, 40% of individuals snorted their stimulant and was usually short acting. And you say, well, that seems awfully high. Well, in our own study, I had seen this study and I said, well, I don't know if I really believe that. But when I looked at our study in 2020, we reported 38% of our sample had snorted their stimulant medicine, which was almost always immediate release. So this is a wake-up call that people are misusing largely immediate release, and half of them are snorting it. Now, does this group sort out? Is it something different? And it turns out that it's the group who have substance use disorder histories that are doing it intranasally as opposed to those without. That's misuse or minus says substance use. This is with. So it really is in the group that are misusing their stimulant medication and have substance use that are doing it intranasally. This is one of my favorite studies. This was done by Tom Spencer in our group, who's been very active with APSARD. And Dr. Goodman was talking about the guidelines, and Tom has been very helpful in helping lead the steering committees and others, one of the co-chairs for the overall guidelines. And Tom's study was fascinating. What he did is he actually looked at the dopamine transporter binding between giving immediate release methylphenidate and extended release methylphenidate. And I'm going to use brand and generic names interchangeably because it's just too hard. This is Concerta, and this would be regular Ritalin. These are equipotent dosing. We know that. If you look under the curve, it's the same equivalent dosing. Let's start over here with the binding in the brain. And I remember that picture I had shown, the figure from Dr. Volkow's work back in 95, where if you had a really steep curve, you had a lot more euphoria. And if you have a slower curve, you had less euphoria. Well, does that work here? So this is a short-acting methylphenidate, steeper curve and more saturation, and then it falls off the receptor faster. This is actually where it's going in the brain. Here's Concerta, slower, not as much saturation, almost 20% less, and it lingers at the dopamine transporter. So what? What does that mean? Well, if you look at likability, higher scores mean more, lower scores are lower. This is the liking the drug effect. This is what DEA and FDA use when they decide that a medicine is going to be not scheduled, scheduled 4, 3, 2. They look at this. This is what happens. Higher scores mean more likability with immediate release methylphenidate. And this is what happens with extended release methylphenidate. You pick this up, and a lot of people go, well, what's that? Well, for those of you who remember, Concerta has an overcoat of immediate release methylphenidate. So you're actually picking up the short-acting component, and then it's down. So there's a significant difference in the likability that we think is directly related to the binding. It isn't related to the amount in the blood because that's the same. That was measured. So what? Is that true? Is that really true with the extended release? This is an older study. I had to dig this out, but this is looking at, again, ER, extended release oros. This is Concerta, has lower likability than immediate release methylphenidate, equipotent dosing 108 to 60. And here is likability, higher scores or worse. This is what happens with immediate release methylphenidate, and this is extended release methylphenidate. And you can see that it's almost twice as much, or 50% more likability with immediate release. You do get some likability that we think is related to that overcoat, and then they drop down. These findings were also replicated in a clinical population. George Bright did a study where he found that there was a lot more misuse in his population. He was tracking that with the immediate release compared to extended release. And around the same time as they were doing this studies, there were epidemiologic studies that have looked at extended versus immediate release and finding lower misuse of the extended versus the immediate. So we're getting one of the signals that's important, which is an extended is substantially better than immediate in terms of likability, and out in the field, less misuse. And then we have ones that are even lower on the abuse liability continuum. So let's start with this. This is methylphenidate. This is Astares. This is the methylphenidate product. This is drug liking. Higher scores are worse, lower scores are better. This is looking at just dex methylphenidate extended release. This is Focalin XR here. And then this is Astares here, equipotent dosing, but this is a prodrug. So this gets metabolized, the serine cleaves from the dexmethylphenidate. You have its overcoated methylphenidate, so it works immediately, but you get that. But I want to point out that Focalin XR, which is a good compound, has more abuse liability than the methylphenidate. So not all of them are the same. And here's Lisdexamphetamine, Vyvanse. This is generic now. And again, you've got lisdexamphetamine with a lysine that gets cleaved, and it cleaves to D-amphetamine. And there's also abuse liability differences between that and others. Here's looking now, this is looking at that, again, Focalin XR. I'm not picking on Focalin XR, by the way. It just happened to be that was the study compared to Concerta. And just want to point, or actually, I'm thinking this may be Ritalin LA. I'm sorry, this is Ritalin LA, and this is compared to Concerta, so relatively equipotent dosing, higher scores, more likability. So this was significantly more than this, and these both were significantly more than placebo. So not all extended release are the same. The more extended release, the prodrugs seem to have the lowest liability. Those with the more intermediate have intermediate liability. The other thing that's come out, and I pointed that out early on, you may not remember, but I said that early start, early duration, we're very interested in that. And the FDA is very interested in that. And this is a study that's just being presented now, where we found that early onset, long duration treatment reduces cocaine and stimulant misuse versus those people who started later. So again, arguments to start earlier. It was not associated with cocaine or compared to the population controls, but you started noticing intermediate duration. If people were only on treatment for 2 to 5 years, you started to see an intermediate risk for prescription illicit or prescription stimulant misuse. And there's still the question is it because you just stopped it and you teased, pulling it away? Did that cause it? Our initial data does not support that discontinuing stimulants causes people to become cocaine or methamphetamine misusers. We're really mining that currently, but it's probably the ADHD effect, we think. And then here, this is something we can always talk about later. This is looking at prescription stimulant misuse and later cocaine and methamphetamine use. Let me explain this. This is looking at kids 18 who are using prescriptions and misusing prescriptions, and then what happens to them 5 years later. This is in JAMA. And this is looking at methamphetamine and cocaine. This is the group that had no medical use or misuse. This is a group that had ADHD and were prescribed stimulant medications and were just using them as said. And there's no difference between these groups or these groups. So you basically convert somebody who's at higher risk for misusing coke or methamphetamine by nature of having ADHD to population controls when you treat them. So that's good news. This, though, is increased. And what is this? This is people who have ADHD, are prescribed medicine, but are screwing around with their own medicine. And there you can see they're at increased risk 5 years later for cocaine use and methamphetamine use, the same as those people who don't have ADHD, where the medicine was diverted and they were just misusing prescription stimulants. Look at that, a quarter of them develop cocaine use. This is not use disorders, this is just use. Another thing we looked at was, so what? So these are short-term, maybe people grow out of things. And what I want to point out is, just to get through this so we can get to questions, basically, if you look 35, out to age 35, you see that there's continued issues. And I'm going to pop right there. Out to age 35, people who misuse prescriptions, either of these groups, have more problems with substance use disorders and other functional issues. I'm gonna, I think because of time, let me see, now we got 5 minutes there. I wanted to talk a little bit about this. I'm gonna, Dave pointed this out yesterday. We should bring this in. So I made a slide about this, but I think everybody knows that they just extended telehealth prescribing. That just happened. So for those of you who didn't know that, take a look online. So it's been extended now. It was going to end or sunset at the end of November, but it's been extended to the end of December 2025. So what are the implications of prescribing stimulants by telehealth? So we did a study through the Mass General program. This question, the biggest question was, if you've never seen somebody in person, a lot of us have not seen our patients face to face. It's been all virtual. Is that different than people who have seen their patients, know their patients in person, and have prescribed in terms of later stimulant use disorders or substance use disorders? not going to go through all of this. Hopefully it's on final approach. I was hoping to be able to say if it was accepted at a top tier journal. So this is a big journal, and we're hoping that this will be done. But it's looking through that. One of the limitations, it's a Mass General Brigham hospital system. Although most of the patients, some of them were mine, but a lot of them were primary care doctors, and we're a big healthcare system. And it's a nonprofit. So this is a nonprofit hospital healthcare system, and I think keep it in context to that. Our finding was a good finding. Telehealth versus in-person was not associated with the development of stimulant use disorders or substance use disorders. That's our sample size. This is the in-person relationship. No substance use had developed the substance use, a very small who had developed cocaine or methamphetamine use disorders. And this is with the telehealth relationship. We had about 700 people. Again, the development of substance use was low. There was no difference in the development of substance use between the groups, and only a few developed stimulant. So we do not see that telehealth prescribing is driving any type of stimulant use disorders or substance use disorders. So what can you do? I just want to end with this. So educate adolescents, young adults, and yourself about this, and you do by just being here. Communicate about medical, psychological, addictive, and legal issues. So for kids going to college, there's an ethical issue if you give away or you misuse your own prescription. But if you give it away to somebody or sell it, it's a serious medical, first of all, it's a medical legal issue because they're going to get involved. And because of the milligrams, it can become a felony offense. It doesn't take many tablets of, let's say, amphetamine, because it's a multiplier, 20 milligram tablets, and you sold 20 of them, you exceed a felony offense. So you have to be careful about that. Use non-stimulants, extended release, or prodrug stimulants in those people that you're worried about. I really push for extended release in college students for a million reasons, but one of them is because of the misuse. Don't overprescribe your quantity. Don't stockpile reserve. It is tempting with stimulant shortages, but it's one thing to have an extra 5 or 6 days, but not an extra 30 or 60 or 90 days. That's where it's coming from. Safe storage is not in medicine cabinets. That's where people look for that. Tell people to keep it in drawers and things like that. And also from a confidentiality, don't advertise you're on stimulants. So these are the things I do with all of the people who are going to college, leaving, high school seniors that I'm worried about in boarding schools and things like that. I have these kind of conversations with people about that. And there's some evidence, Brooke Molina did a study that shows if you use components of this, it does help over the long haul. So I'm going to end by saying stimulant medicines are the #1 misused prescription medicines. It's associated with increased substance use, deviant behavior, morbidity, and prevention and ongoing monitoring is what's required. And by the way, that monitoring doesn't necessarily mean that you're going to be doing urine testing or oral fluids. I would only do that for people who are highly suspect for substance use disorders and you're worried, or people you're worried aren't even taking their medicine. But we don't use that. We use routine questionnaires and stuff. And here's the team. I want to thank, again, funding for this came from the Food and Drug Administration, National Center on Drug Abuse. And it takes a village to do this kind of work because there's so many people involved. So I will stop share screen here. If I can get that, sorry, a second. There we are. David, I think you're muted, which is actually great. I think we're very profound.
Yeah, even in an audience of 70, 80 people, you're still taking pot shots at me. That was an incredible distillation of the literature and also what makes you particularly unique here. I'm grateful you consented to this, is that you're a clinical researcher and you've highlighted the fact that not only do you contribute enormously to the field, but you actually see patients. So the distillation of the meaning of this to treating patients is really critical. I just want to make one note. There's an interesting history to amphetamines, which you probably know, and that is the use of amphetamines in World War II for fighter pilots. After World War II, the military then started doing studies of performance, and what they found was that the pilots on amphetamines thought they did better than in fact they did. So decades later, we're confirming that your subjective experience of improved performance may not actually be true. So it's very historically interested. Let me get to the questions here. We have several. One for a point of clarification. How do ADHD people, quote, misuse their own prescription? Properly prescribed stimulant treatment for ADHD brain generally doesn't result in addiction, euphoria, otherwise pleasurable experience. So what are we talking about? Can you clarify that?
Yeah, that's a great question. And first of all, I just want to comment about the expectations and what you just said. I wish I'd have known that when I found that later, but when we were doing this paper and examining that, it was really shocking that these laboratory models really replicated exactly what happened. They found precisely that. And I think it's helpful for people to know. It was if you thought you were doing better, and you thought you did better if you got the stimulant, and you even thought you did better if you had the placebo because of the trial, and it really wasn't the stimulant. So we looked at that. So I found the first time we found a signal on that was back published in 2006, almost 20 years ago. And as I said, our divine angels in our own clinic that we treat, and thanks, David, for the comment about treatment. I treat a lot of people with ADHD and have accumulated a big patient caseload, but our group does. And so we looked at that, and what we found was about 20% of our individuals were misusing their own stimulants, pretty much exactly what the current survey data shows. And some of the things they did is about 10% were using them just to get high. So what they would do is they would ramp up the dose, or they would grind it and sniff it, because we were using short acting. We didn't have a lot of extended release at the time. Another thing they do is they would use them at night if they were partying, because it helped them stay awake. So they would do it when they would get tired on alcohol or cannabis, and they would use stimulants at the same time to keep them awake. Those tended to be the two biggest ways they were misusing it. And then we had people who were late on projects, and they would just amp up the dose and do the equivalent of a rave. They would just pop them all through the night for 2 days straight, like on a weekend, to be able to get some kind of a project done or something like that. Those were kind of the big buckets that they live in. And that seems to be what the literature now, these big survey studies are showing in much bigger samples.
One of the things I do in clinical practice to assess reservoir growth is to ask people, not are you taking it regularly, but I ask them, how many days a week do you miss that second dose? And if they say, well, 3 or 4, then I can calculate the increasing reservoir. And that's really important to find out. And then I will not prescribe for a period of time to see how long that lasts. And then they call and say, I've run out. And so just the clinical insights of assessing the reservoir growth and where those pills end up. Have you looked at rates of people misusing stimulants in college population for weight loss? Is that part of the equation on the increased misuse?
Yeah, we did. That's a great question too. We did in our NIH study. That was one of the reasons. It was a small sample. It's like 4%. And because of our sample size being so small with stimulant misusers, I didn't make much about it, but it wasn't a big number. It was like 4 or 5 of 100. So it doesn't seem to be driving as much as what we would have thought.
So maybe the academic environment promotes misuse for performance, but the question here, another question, appreciate the high rates of stimulant misuse in college students. Does that remain true for those in higher education, such as graduate school, medical school, law school? Wondering if the reason for stimulant misuse is tied to being in an academic environment.
Yeah, and the answer is yes and no. So what we know would indicate that Gaussian troop, it does start to fall off in graduate school, medical school, law school. So you see a precipitous drop in that. And we're not seeing appreciable amounts in those samples. But then the comment about more competitive, the answer is yeah, you see more and more competitive institutions, no matter what regions you're looking at. So the more misuse lines up with the more competitive or tough the institution is.
Okay, good. Has stimulant misuse been looked at in areas with high healthcare disparity, i.e., getting it from a friend because they can't afford appropriate medical services? These are down in the weed, great questions.
Yeah, and our attempt to look at that was to examine our national survey studies, and we've published papers on looking at it by sociodemographic factors and did not see huge differences in that. There are a number of disparities in ADHD care, however, that have come to fruition, and there are people who are looking at that. But in terms of that specific question, the first look at it didn't seem to show that. It's an interesting, very interesting question, and we didn't see that a huge signal for that.
I've been on the guidelines task force. You're currently on the guideline task force. It's a arduous academic exercise. And the question here, is there an update on when the new guidelines might be published?
I would say when your grandchildren's grandchildren graduate college, it'll be out by then. It's your guess is as good. It's taken a while, but it's because there's a process that's being followed, et cetera. The good news is there is sort of wrap on the first drafts, and then it has to go through this iterative process. So there is quite a bit of progress.
So now that Dr. Wilens was a little snarky on that, it is a very detailed process, and I'm not sure the audience understands the difference between a consensus report and clinical practice guidelines. If you scan the QR code there for the psych annals, there are several articles, one of which I wrote on the details of what's involved and how we have to follow protocols by the Institute of Medicine, the American Psychiatric Association, all the detail, the steps and the technicality. The other aspect in the United States is that the guidelines have to be submitted for public comment. And so for the advantage of lived experience, diversity, and inclusion, we need public comment on the guidelines, which will be then incorporated into the guidelines. So there are a lot of stakeholders waiting for all of this input. I was on a call today with people in Ireland who are querying about how the United States handles the ADHD population, since they're having a huge burden amongst their primary care, their GPs, and limited psychiatrists, because people are coming in. And it's clear that the world in general really has a difficult time understanding ADHD. Tim, I wonder if you could just comment. I mean, that we've gotten into this position in part because, in my opinion, it's not been a focus of psychiatric and professional training in the professional training programs. I know at Harvard, you have a whole triumvirate of researchers who are educating residents, but generally people aren't educated. And so there's this prejudice amongst clinicians, some of whom believe in ADHD, some of whom don't believe in ADHD, and how the guidelines will then translate into some parameters and guardrails for the consistent standard application of clinical practice for ADHD.
Yeah, I mean, what I would say is absolutely, and organizations, for example, again on that webinar with the Drug Enforcement Administration, one of the first things they said is there are no guidelines for the treatment of ADHD in adults, and they're very concerned about that because they said there's no best practice that's really out there about how long do you do an assessment, how often should you do follow-ups, what do you, and so I think everything you said, David, is very well taken.
We have 2 minutes. Tim, do you want one last bullet point, one last sharpen the pencil information you want to convey? Again, I want to tell you that was to put together a talk that's so concise. It was just remarkable. So I thank you, and I hope all the people who signed up today really appreciated what you brought to the webinar today.
Well, I appreciate that. I have to say, everybody, it was so much fun because this is work we've done over the years. And I had to open up PowerPoint from old slides. I always like to bring old and new in, and some I couldn't bring in. So I couldn't bring in a couple of the studies, but it's a lot of fun to do it. And again, I think it's a proscriptive shout to all of us to just monitor this. Don't freak out, ask questions about it, talk about it. And I think doing that is going to move the dial. I really do. Just doing all of these, by the way, are available. The slides are made available to you. You're welcome to have them. Anybody who wants the slides can use the slides. If you need the slide copies, we're happy to get all of that to you. Because a lot of you are out making presentations about this. Feel free to use whatever slides you want.
Very generous. Thank you. I just want to highlight for those of you who are not members of APSARD, it would be to your benefit if you're interested in this area. to look into our organization, to join as a member, to access all of the webinars as well. Again, this is an organization with national and international experts. This is the state of the literature and will help both you in regards to education, but also help inform your patients who are subjected to Dr. Google and his resident, Dr. TikTok. So I hope you'll take advantage of what we have to offer. Tim, thank you. I can never thank you enough for your help and educating everybody. And thank you all to those who remained on here, and hopefully it was useful. Thank you, Suzanne. I'll turn it back to you.